everybody, welcome to the second episode of our case Look at the Behavior. My name is Sahar El-Egeimy, I'm a fellow in MIC, and I'm gonna take you to a quick review and a gentle reminder of our case. My case is 4 years old child. She is having difficulty of initiation of the saccadic movement. So as we see in this video, she is having a rapid head turn to the left side in response to the left saccade, what is called the head thrust, followed by smooth pursuit movement of both eyes towards the left side following the target to overcome this situation. Also, we are having the photos of the MRI of this child showing a characteristic sign which is the molar tooth sign. To make it more clear, this is a picture of the MRI of a typical molar tooth sign with deep interpeduncular fossa, thick and elongated superior cerebellar peduncles, cerebellar vermis hypoplasia, and there is a comparison between the MRI of the normal person and the person with molar tooth sign. So we diagnose this case as a case of oculomotor apraxia, which could be congenital due to congenital malformation as Joubert syndrome, which is characterized by defective horizontal saccades, or acquired as perinatal problem as CP or hydrocephalus or neurodegenerative conditions. Also could be associated with other diseases like herpetic encephalitis, posterior fossa tumor. So with these findings and the characteristic MRI finding, we diagnose the case as Joubert syndrome. Let me take you to the answers of the quiz. The first question was, what are the important signs in this case? And the answer is D, all of the above. As we noticed, the head thrust, the normal pursuit movement, and difficulty initiation of the saccadic movement in the video. The second question was, what is the most serious complication of this condition? And the answer is B, renal failure, as all of these complications occurs in this case, but apnea, for example, occurs in early infancy and subside at the age of 6 months. Renal failure occurs in older children. And now it's time for our commentators. Professor Dr. Arif Khan, he's a professor of pediatric ophthalmology, Cleveland Clinic, Abu Dhabi, and he's a regional expert in ocular genetics. And Dr. Mahmoud Yusri, he's a consultant of ocular genetics and founder of Ocular Genetics Clinic in New York, and he's a researcher of ocular genetics and division of human genome in the National Research Center.
Greetings from Abu Dhabi, and thanks for inviting me to comment on this interesting case. This is a case of a 4-year-old girl who was seen because of complaint of abnormal head position. She had intellectual disability, hypotonia, certain facial features, and an inability to look to the side with saccades. She would use a head thrust to follow an object of regard to the side. This phenomenon is due to inability to voluntarily initiate saccades, and it's sometimes called oculomotor apraxia. It's commonly called oculomotor apraxia, but I prefer the term saccadic initiation failure because it more accurately describes what's going on. When I see a child with saccadic initiation failure, 3 major possibilities come to mind. One is Joubert syndrome and related disorders. The other is ataxia telangiectasia, an ataxia telangiectasia-like disorder. And the third is isolated saccadic initiation failure, which can be a familial trait. In this particular girl, in the context of the intellectual disability and the facial features and hypotonia, the diagnosis of Joubert syndrome and related disorders is on the top of the list. This is further supported by the abnormal VEPs and ERGs, and the diagnosis is clinched by the characteristic MRI finding of the molar tooth sign, abnormal configuration of the superior cerebellar peduncles. Joubert syndrome and related disorders are part of a group of genetic diseases known as ciliopathies. These are defects in genes responsible for cilia maintenance. We think of cilia as these motile structures that move fluid and mucus around, like in the respiratory tract, but in fact almost every cell of the body has a non-motile cilium. Non-motile cilia are important in embryogenesis, cell signaling, cell trafficking, and a variety of other functions. Ciliopathies often can involve multiple organs, And in Joubert syndrome and related disorders, there are potential problems neurologically, in the respiratory syndrome, in the renal disease, the liver disease. I'm not going to go into that. I just want to concentrate on the characteristic ophthalmic features. Of course, we've already discussed the saccadic initiation failure and head thrusts. Something else that we commonly see in Joubert syndrome is retinal dystrophy. This is because the connection between the outer segment and inner segment of the photoreceptor is a modified non-motile cilium. There's also a classic form of nystagmus that we can see in Joubert syndrome, seesaw nystagmus. This is related to a chiasmal miswiring, and in fact, in Joubert syndrome and related disorders, the ciliopathy defect does cause abnormal decussation and a miswiring defect. Other things that we can sometimes see in Joubert syndrome are ptosis, other forms of strabismus, coloboma, and motility abnormal synkinesis as well. In summary, Joubert syndrome is a genetic disease, but it's really a clinical diagnosis. Ophthalmologists are uniquely able to suspect the diagnosis when a child comes in with characteristic facial features, hypotonia, intellectual disability, and saccadic initiation failure with head thrusts. The diagnosis is clinched by the MRI finding. Thank you for putting together this forum. Thank you for this interesting case. And thank you for including me. Kula amun bikhair, Ramadan Kareem.
Everybody, this is Dr. Mahmoud Yusri, the founder of the Ocular Genetics in the Mayor. I'm a researcher of clinical genetics at Clinical Genetics Department, Division of Human Genetics and Genome Research, National Research Center. This is a reminder of our presented case. She is a 4 years old female. This is the family pedigree showing that the father and the mother are first cousins, and they have a normal male and affected girl. She presented with oculomotor apraxia. She was referred from Dr. El-Egeimy, and she had delayed motor and intellectual disability. And she was presenting with oculomotor apraxia, and today we are going to discuss the causes of oculomotor apraxia. Oculomotor apraxia have a genetic causes and acquired causes. From the genetic causes, we have congenital oculomotor apraxia, Joubert syndrome-related disorder, Polytypic syndrome, ataxia with oculomotor apraxia, type 3 and 4, ataxia with oculomotor apraxia and hypoalbuminemia, type 1, and spinocerebellar ataxia with axonal neuropathy, type 2. The most common cases we see with oculomotor apraxia are Joubert syndrome and Polytypic. Polytypic syndrome has oculomotor apraxia. When we do the MRI scans, we don't find the characteristic molar tooth image in Joubert syndrome, but we find cerebellar dysplasia with cortical and subcortical cysts in the cerebellar, as shown in the figure in front of us. Joubert syndrome, you can see on the left side image the molar tooth sign in the T2 weighted image in the axial view, which is characteristic of Joubert syndrome. On the right side image, we can see in the T1 weighted image, axial and sagittal view, we can see in the sagittal view the characteristic molar tooth image, while on the sagittal view, we can see that the superior peduncle is thickened, maloriented. The acquired cases are often in adult cases. They are bilateral lesions of the posterior cerebellar hemispheres and bilateral basal ganglia infarcts. They are not seen in pediatric age group. So what we do next, we do brain imaging by brain MRI and refer the patient to the neurogenetist or ophthalmogenetist. What's the aim of the referring the patients? We aim for proper clinical diagnosis for anticipation of complications like we have discussed in Joubert syndrome. They have complications in the form of renal affection and liver affection. We do proper molecular genetic testing, and then for proper genetic counseling for the subsequent pregnancy, which is more important for the family and to help them in the subsequent pregnancy, either by doing prenatal diagnosis through fetal imaging or amniocentesis, or we can help them by doing PGD to prevent the occurrence of the disease in the same family, as most of the cases are autosomal recessive disorders. So this is the more important issue from proper genetic counseling. Thank you everybody for listening.
Greetings to everyone. I'm Ahmed Awadien, Professor of Ophthalmology in Cairo University. My patient was a 40 years old male patient working as an engineer. He complained of bothersome vertical and horizontal diplopia. There was no gaze position where the patient can get satisfactory fusion. The patient had a history of motor car accident 7 months ago. The patient was diagnosed with a fracture of the left orbital floor, and he had an orbital floor implant 1 week after trauma. In the primary position, the patient showed a left exotropia and a left hypotropia. Examination of the ocular motility revealed limitation of elevation, particularly in adduction, together with what looks like a left superior oblique overaction. In the primary position, the patient showed a left exotropia of 15 prism diopters and a left hypotropia of 25 prism diopters. Both the exo and the hypotropia increased in right gaze and decreased in left gaze. In up gaze, there was marked increase in the hypotropia, while there was a reduction of the hypotropia in down gaze. This was associated with a small A pattern. On right head tilt, there was an increase in the left hypotropia, while in left head tilt, there was a reduction in the left hypotropia. On fundus examination, there was a +1 fundus intorsion of the left eye. And on double Maddox rod testing, there was a subjective intorsion of the left eye of 5 degrees. What is the cause of the double vision in this patient, and what are the muscles possibly involved? And how are you going to manage this case? Ramadan Kareem.